start with, has seen significant advancements, and with that has come the expectations have also gone up. With the advancements in the cataract surgery, the expectations of the patients have gone up, and the high expectation translates into the higher risk for the practitioners. That ranges from unhappy patients to potential legal implications. Hence, it becomes extremely important to have accurate measurements, because if the inputs are not right, the outputs will not be right. Hence, this talk about accurate IOL power calculation. With the changing profile of this cataract patient, where they're expecting visual outcome to a refractive outcome, and with the number of available advances in the IOLs in the market and more advances pouring in now and then, it becomes very important, because these cases are very sensitive to miscalculations. Also, the benchmark standards for refractive outcome has been revised in 2006, where the expected outcome should be within plus minus 0.5 diopters for at least 50% of your cases. So the recipe for IOL power calculation, we input these basic data into an appropriate formula to get the IOL power. But there are other variables which are required to do an accurate IOL calculation. The possible sources of error increase as the variables increase. The systemic errors are the avoidable ones, which are due to weakness in formula or the measurement technique. Axial length. This is when even a millimeter counts. It can be measured using ultrasound biometry or partial coherence interferometry. If we know, the most common ultrasound methods used are is the contact method or the immersion technique, A-scan. As you can see in the readings, the readings of both these techniques would be same, with difference in the number of spikes with the contact method, because there the probe and the corneal spike is one, which splits into two in the immersion technique. Can I have a pointer, please? What you need to know about the A-scan readings, it's important to know these terms. Spikes, which is we need to know about the amplitude of the spikes and the number of spikes. The gain is again signifies because is significant because it gives a resolution. Higher gain, there will be blurring of the spikes into one another, and at low gain you can miss some of the interfaces. Gates, again an important term. These are the gates, which are nothing but electronic calipers, which are used to calculate distance between two interfaces. The importance here of the gate becomes is significant when there is a condition like dense cataract, where there will be multiple spikes within the lens. So you might have to align manually the gate to the posterior lens spike, giving to get the accurate axial length. So it's important to know your readings right. The good scan should have I'll use this picture for now. The good scan should have high amplitude spikes, equal in size. The spikes should be perpendicular from the baseline without any slopes or humps right before the retinal spikes. And you should be able to know about these poor scans. You have to avoid them. And also important to know are the average measurements of the eyes. Be suspicious if your readings, the axial length readings, are beyond the average measurements. The difference between the two eyes is more than 0.33 millimeters. And absent scleral spikes means your probe is not aligned. It has to be aligned with the visual axis. you have to validate if any of these suspicious situations arise, and you have to take a series of measurements, discard any aberrant readings, and practice, and more practice. There are a few challenging situations in very dense cataract. You can use higher gain settings, and you might have to manually align the gate. Posterior staphyloма, again a challenge. A B scan would be helpful. So which one is the best? Contact versus immersion. So variable corneal compression is inevitable, even in experienced hands. It's very personal dependent, and an average error plus minus 0.2 millimeters converting into 0.5 is significant. As you can see in this picture, the error of 1 millimeter in an average eye accounts for around 2.5 diopters, which can go up to 3.75 diopter in short eyes, hence the importance. The reasons to change are compelling. Now, ultrasound versus optical. The ultrasound-based measurements, all the ultrasound-based measurements have limitations. That's because they use broad sound beam to measure a small distance, and they measure only up to internal limiting membrane. And by definition, axial length is the optical axial length is distance between corneal vertex to the center of cornea. As you can see, the beam doesn't even reach the center of cornea, where the sharp beam used by the optical biometer reaches all the way to the retinal pigment epithelium. The optical biometers available in the market these days is the IOL Master 700. They give consistently accurate and repeatable results, measures many other parameters required in most modern formulas, and they are incorporating most modern formulae for IOL calculations. The Lenstar 900 is one scan, 9 measurement, 30 seconds. It's fast, gives more measurements, and it has additional features of 2-zone auto keratometry, which gives perfect K values and best toric results. Also added are Olsen formula and Shama's and Maskett formula for post-refractive cases. The AL scan by NITAC is claimed to be even faster and can be used even in dense cataract. And it has an optional inbuilt ultrasound and also assisted toric alignment. But optical biometers are not always helpful, especially when the media is hazy. Any haze in any opacity in the optical media, the optical biometer is not going to work. Hence, do not throw away your old US machines. Measuring corneal curvature, we are very familiar with these pictures. Sources of keratometry errors arises when there is unfocused eyepiece, failure to calibrate, poor patient fixation, dry eye, etc. Remember to always calibrate. Perform keratometry prior to any applanation testing. Revalidate your reading if there is any doubt, especially when the corneal curvature is out of range. Their topography is preferred. And the difference in average corneal power is more than 0.9 diopters between eyes, as given by Dr. Warren Hill guidelines. Keratometry for toric IOLs, again important because of the increasing number of astigmatic cases. So manual keratometry is better, and topography is used to confirm if astigmatism is regular to exclude the keratoconus. And if you're using automated K readings, validate 3 with at least 3 within 0.25 diopters in each principal plane. The shortcomings, the cornea is aspheric, and that is not presumed by these devices, hence they have these shortcomings. I would like to mention about Pentacam here, which uses rotating chamfer camera, measures both the interior and posterior corneal curvature, and gives us equivalent K reading, which can be used with different formulae even for the post-refractive IOL calculation. Now, important parameter is effective lens position. Human eye being a dual lens system, the effective lens position, which is the position of the pseudophakic IOL that you will be implanting, that would define the total power, effective power of the system, the eye. It is distance from corneal vertex to principal plane of thin IOL. As you move the IOL towards cornea, the total power of the eye increases. Now, ELP, the most striking difference between the modern and the original formulas is the manner in which the ELP is calculated. from yesteryears when it was just a constant to recent advances where more and more variables are included to predict the ELP. A personalized lens constant is important to have. All the lens, depending on the IOL make, design, would have a constant which needs to be personalized by the surgeon. To start with, use the manufacturer's constant and then reevaluate your case, reevaluate after a few cases. Formulas. It has been broadly divided to theoretical and regression formula and generations first to fourth. Most commonly used formulas and given the axial length, depending on the axial length, these are it's a very popular slide. The Hoffer Q is most accurate for the shorter axial lengths. Holiday 1, SRK2, 22 to 26 millimeters. Holiday 1 is good for longer axial lengths. Holiday 2 and Hage's, as you can see, when it is optimized, is good for almost all the axial lengths. I would be skipping these slides. We know about the SRK formulas. The third generation was a merger of linear regression method with theoretical eye models. And the major drawback was assumption that the anterior chamber depth is proportion of axial length and not a true measurement. That's why there were IOL surprises in post-refractive cases. That led to advent of the fourth generation, which generation IOLs, the formulas, which are Hage's formula, Holiday 2, they consider ACD as a true measurement and they calculate it. I would be talking about special situations. I'll be skipping this section because Dr. Roberto is going to cover that. But we use Hage's L formula and the results have been really good with that. Talking about eyes with silicone oil, either use optical biometer or what we are doing if it's not possible because of the media opacity. We use A-scan, changing the velocity of the vitreous to 981 to get the near accurate readings. Olsen formula is using C constant is a new formula again, and the Olsen formula uses exact ray tracing, and the approach predicts ELP accurately. Toric IOL calculations, there are various websites. Every company has come out with their own calculator, which you can find online. And this calculator, which you can find at www.drhill.com, it's going to help you know your surgical induced astigmatism. In very long eyes, it's recommended these days formula which has the axial length in more than 25 millimeters using these four formulae. And the universal formula by Dr. Graham Barrett is very popular these days again. And it can be found at the ACRS website. You can you can feed in your readings and get the IOL power. In microphthalmos, Holiday 2 formula, even when only the posterior segment is smaller. Hoffer Q, when it's more useful when there is a proportionally small anterior and posterior segments. Very small eyes, again, Hage's formula, as we've seen before, is most accurate. It also depends on the haptic design, open loop versus plate haptic. That may influence ELP in very small eyes. IOL power calculation in children, a very debatable issue. I don't have time to cover this topic, but what we use at our center is these factors. The age at cataract surgery, because of the growing eyes, we need to leave residual refraction. How much depends on these factors. That's the protocol that we follow. Now, validation guidelines for IOL power. You have to be watchful when there is IOL power for emetropia greater than 3 diopters, different than anticipated. And the difference in IOL power is greater than 1 diopter between two eyes. If the patient has had prior exam or laser-based refractive surgeries and the calculated IOL power for standard phacoemulsification is less than plus 17 or greater than 23. To conclude, try to use optical biometer. If you don't have one, please use immersion ultrasound for accurate axial length measurement. Use 4th generation IOL formulas if possible. Always personalize your lens constant. Examine and reevaluate your results periodically. Thank you so much for your attention.